Hello again. So I have the pleasure of introducing Dr. Tom Steineke. Dr. Tom, I like that, is trained at UCLA in neurosurgery and then went on to do a 2-year fellowship in pediatric neurosurgery at University of Pittsburgh. Dr. Steineke is the director of pediatric neurosurgery here. He is also associate director of the Children's Neurological Center, and he is the surgical director of the Comprehensive Brain Tumor Center program, whereas I am the medical director. Tom and I have worked together for the last year. He is an excellent neurosurgeon, adult and pediatric, and he's going to talk about some of the techniques that we use to treat our brain tumor patients.
Thank you.
Dr. Tom.
Good morning. How are you doing? Thank you for inviting me here to speak. Have you ever had one of those days? Friday was one of those days for me. I had this plan, grand plan. I'd see a few patients, work on my talk, get everything spruced up. Well, I knew that plan changed when first thing I did was broke my foot. And then I got to work and found out that I had an emergent case, and I was in the OR till late last night. So the talk didn't get spruced like I wanted to, but I think we'll have a good time anyway. So thank you, Joe, for the kind introduction, and I want to talk about advances in neuroimaging and mapping. It's going to be heavily on the neuroimaging because it really has instructed the mapping, and then we'll look at a little bit of mapping as well. So first of all, I just want to give you kind of a roadmap of where we're going. We'll look at the history of neuroimaging a bit, we'll look at some modern imaging, the latest advances, and how they reflect and contribute to patient care, and we'll look also what's on the horizon. First of all, before the 1970s, CT wasn't invented yet, so they had to do other methods of trying to diagnose a brain tumor. One of those was a cerebral angiogram, basically injecting dye inside the vessels and then taking pictures, or basically skull x-rays, and looking for things that appeared to be tumors. For instance, this is called a tumor blush. It was classically done in the carotid artery. Basically, they stuck the neck, and there was a greater risk of stroke at that time, especially in older individuals. You can imagine plaque on the carotid artery as you're sticking through it, and also risk of arterial injury. It was difficult to truly localize the pathology, as you might imagine. This is, it's somewhere in the brain, but it's kind of difficult because you correlate this with the patient's head and you feel a few bumps and you hope you're in the right place. It's also nearly impossible to develop a differential. For instance, this could be one of a dozen or so things. And furthermore, many tumors are not highly vascular, and so you might miss a tumor.
Okay. I just wanted to tell him his car was being towed. No, I'm kidding.
All right. Do I need to project more, or is it hard to hear in the back? All right. Okay, the second method was an air ventriculogram. And essentially that was, they did a lumbar puncture, in other words, stuck a needle in the back, sucked a bunch of CSF out, and put a bunch of air in. Now, if anyone's ever had a lumbar puncture with taking a few cc's of CSF, you know that it's very painful and it causes tremendous headache. So this is a very uncomfortable procedure. And as you see, it's kind of subtle to see what's going on here. Here the ventricles are actually outlined. And this is some air in the frontal part of the brain. So basically they would look for compression or basically shadows along the ventricular surface and try to make a guess of what was pushing the ventricles around and why. Another method was basically more direct. They would drill a hole in the skull, put a needle down, suck CSF out, and put air in. Again, mind you, this is a diagnostic procedure. Again, it's difficult to truly localize the pathology, and it was nearly impossible to develop a differential. During my preparation for this talk, I ran into a note from actually Dr. Cushing's patient. He was like the grandfather in neurosurgery. And just to illustrate the point, this was their diagnostic procedure. Basically, they took the patient to the OR, shaved the entire head, which namely, mind you, for any of my operations nowadays, I don't shave at all. made a 3-centimeter incision, an inch and a half incision, drilled a hole, and put a needle into the brain. So I understand that MRIs are uncomfortable, but comparatively, they're a walk in the park. And with doing that, they read the ventriculogram, and when they went to surgery, it still was exploratory, because they basically went in, looked around, didn't find what they thought they would find, closed, and decided to come back for another day. So fortunately, imaging has improved, and with it, neurosurgical procedures. So anyway, just to summarize, classic imaging looked only at secondary characteristics, the vascularity of the lesion, the amount of mass effect it was causing. Also, is difficult to localize, and impossible to get a differential by just the imaging. You had to take a piece of the lesion. And so exploratory brain surgery was more the norm. So in the modern age of imaging, it was revolutionized essentially in the mid-70s with the introduction of the CAT scan. Head CT. This really revolutionized both radiology as well as neurosurgery. For the first time, we could see the brain. We could see, and this is about how grainy it came out in the mid-70s. The CTs nowadays are beautiful compared to this, but still, this was leaps and bounds ahead of what they had. You could see the brain. You could make out white matter. You can make out the gray matter, if you use your imagination. And you could see the bone. Much more detailed than previous methods, and able to localize your pathology. With a little bit of contrast, you can see that this is a tumor pushing ahead. And also, there's going to be different imaging characteristics of the different tumors, so you can start getting a non-invasive way of making your diagnosis. Also, it's very good at looking at bone. This is obviously a fracture here. And it's very good at looking at blood. This is a contusion in a patient who had a brain injury, but it's also very good at looking at blood with tumors that bleed, and it's not infrequent that we see a tumor that bleeds. Not as good as at the subtle changes in the brain or subtle pathology or the detailed anatomy. And thus, in the mid-'80s came the MRI with exquisite detail of the anatomy, much better pathology, and better able to make a differential diagnosis. Also, you can scan in 3 planes relatively easily, what we call the axial plane. Again, this is the front of the brain. This is the back of the brain. And so you see with exquisite details the white fibers, the white matter tracts, the gray matter on the outside, inside with the ventricles and the deep nuclei of the brain. So it gives us a tremendous ability to localize lesions and make a differential diagnosis just by looking at the imaging. For instance, this is how we make a differential. This is a patient that has something large in the middle of the brain, and it's what we call iso-intense of the brain. In other words, it looks very similar to the brain on MRI imaging. Adding contrast that lights up like a light bulb. And the next image, you can also see that it has a very good plane, as we call it. There's a separation between it and the actual brain. So this is classic for a meningioma. So this is a way that we can look at images non-invasively and start to have an idea of what type of tumor that we're dealing with before ever doing an invasive procedure. However, this does lead to some problems. Can't see the bottom of it. Basically, it says we've given you a brain scan and we can't find anything. Neuronavigation. So in the 90s, in the late 80s and 90s, we started developing the technology and bringing it into the operating room, making it more interactive and more applicable to clinical neurosurgery and the operative theater. First of all, we correlate, basically we use a computer, have the images in the computer, and we correlate that with the patient in space. It's pretty complex computing, so I can't get into that. I'm not a computer scientist by any means. But we basically show the computer where the patient is, and then we can point to different parts of the patient and the computer will show us the pathology. This is an example. The patient, you might not want to see this, but the patient is in the head holder. And these are what are called fiducials. These will be points that we tell the computer where they're at. And this is basically shows the computer where this whole thing is in 3D space. So the computer recognizes this. We then show it, we put a pointer here that sends a signal up, so it knows where these 3 points are, and then is able to extrapolate where everything else is in the brain here. And this is a picture of that person registering it to the computer. Again, this is what this is plugged into the computer. It sees this, so it knows where everything is in space, so you just have to tell it where the brain and the head is. So what does this do for us? This gives us the ability to use a pointer, and that pointer will show us exactly where we're pointing to. Therefore, we can plan our operations and plan our openings such they're small, directly on target. So this basically is a pointer that they're using to point where the lesion is. You can see it in this 3D reconstruction. There's several other views that you can see it in. And then you can actually have your scope tuned to the computer as well. So when you're looking through the microscope, it will inlay the area where the tumor is right on your image. So this gives us a tremendous opportunity to shrink our craniotomies, make them smaller, as well as be right on target when we're operating on tumors. This is another example. This is a tumor at the front base of the skull right here, and you see it over here. And this also shows an advantage in neuronavigation. It's taken an MRI image and has fused it to an CTA image, which is an image that looks at blood vessels. So now we're able to fuse different data sets, so we can look at blood vessels as well as the brain and come up with these beautiful images. It keeps us out of trouble, and it also allows us to direct things and be very precise when we're operating. This is another example of a deep-seated lesion. In the past, you'd have to do a big opening because you didn't want to miss the lesion. You'd have to do an ultrasound and kind of sneak your way up on it, hoping that you'd actually get there. With neuronavigation, you can do, a $half size opening and dive right down into the lesion, even though it's 3 or 4 centimeters below the surface. Again, this is the probe on the lesion in the different planes, and this is a lesion. It happens to be a small vascular malformation. So neuronavigation, it basically makes things interactive with the imaging in the operative theater. Like I said, it allows us to more accurately localize the lesions. It improves our planning, allows smaller, more precise openings, which essentially minimally invasive techniques, which is one of my areas of interest and one of my specialties. It increases the safety, especially of deep-seated lesions, and helps define the surgical borders or the tumor borders. Now, I'm basically going to give you a potpourri of what we do in the OR. I'm not going to go in a long discussion, the pros and cons of each technique. I think that would probably bog us down. Of course, there are downsides of any of these techniques, and we can get more into that if you're interested. I'll be happy to talk to you afterwards. Functional MRI. Probably everyone's heard about this, and so what exactly is it? Functional MRI looks at the way an MRI scan works is it has a huge magnet. It sends a magnetic field to your brain, which stimulates the molecules inside the brain, basically puts them in a higher energy state. They turn it off for a flash. Those molecules go down to the normal energy state, and they release energy. Each molecule and type of tissue has a little different signal. So therefore, you get these nice images of the brain. And that's as much physics I'm going into, so don't worry about it. I'll put everybody to sleep if I get into too much physics, including myself. Anyway, so functional MRI takes advantage of the difference in the way that hemoglobin acts when it has oxygen when it's carrying oxygen versus when it's not. Active tissue pulls out the oxygen of hemoglobin, becomes deoxyhemoglobin. It has a different signal than oxyhemoglobin. So active areas of the brain have less oxyhemoglobin, more deoxy, and the scan can detect that. So when we will ask you to do a function, for instance, repeat words, and then we'll image your brain, and the areas in which have less or more deoxy, in other words, are more active, those are assumed to be the speech centers. That's kind of in a nutshell how it works. However, it's only as good as the protocols, meaning it's only as good as the techs that are doing it, and how good they are at asking you the correct questions and eliciting the correct answers. So what does this mean? Well, what do we mean by mapping? As everyone probably knows, the brain has dedicated areas for function. The motor strip, remember the right side controls the left side of the body and vice versa. The sensory strip. So these are the areas that we're very concerned with the lesions near that. Also on the left side, classically you have Broca's, which is a speech center. If you lose that, you have a hard time speaking and forming words. You can think of them, but you have a hard time saying them. Then Wernicke's area is another area, speech center, that we're very concerned about. It's devastating if you get a lesion in this area. And that's an area where you're very fluent, but a lot of times the patients will just speak gibberish if they get a lesion there. So whenever we have a tumor that's near these areas, pardon me, then we will want to do a functional MRI and see the relationship of the tumor to that area. So just to give you an example of how this works, this is a lady that's in her who's 26. She presented with a seizure, but it was otherwise okay. She had this lesion, which is a low-grade glioma. I'll tell you that up front. Now, this is concerning for a surgeon because we know somewhere in here is the motor area. So you do a functional MRI, and there's basically testing both motor with a motor skill, tapping, and sensory with them feeling something on both the right and left side. And this shows you the motor area right here, and it's right behind this lesion. And then the sensory area is, as expected, is another gyrus behind. And we test both sides. Okay. And again, this just shows you the testing in the different planes. Looking in the sagittal plane, again, you see it lighting up here, and see the proximity to the lesion. This is, we integrated it with the regular MRI, and we plugged it into the neuronavigation. Therefore, we could point on the neuronavigation to this area, and we know that correlates to an area of the functional MRI that's positive for the motor. Okay. This is what it looks like interoperatively. There's two ways that you can do this. First of all, you can just simply go with the neuronavigation, or you can electronically test it by stimulating these areas and defining where the motor strip is electrophysiologically. And that's typically how we do it. So you see we've mapped it, and then we felt that this area was safe, and the motor area is behind it, so this area, the lesion was resected. Now, mind you, when you look at an area in front of the motor strip, just because you stay out of the motor strip doesn't mean you're not going to have a deficit, because there's an area in front of the motor strip that basically tells the motor strip what to do. So it's usually transient, but you will have a deficit. The post-op scans look beautiful. There's a little bit of blood inside the cavity, but otherwise is a gross total resection. She initially was weak as expected, but she resolved to full strength with some rehab in about 6 weeks. Another exciting, so basically we can map the brain. We know what the gray matter is doing, but one of the problems up to a few years ago is we didn't have an idea of what the white matter was doing. We had no way of And the white matter is the connection between the areas of the brain. So we knew what the surface was doing, but we really didn't have a good idea of what the cables between the areas were doing. So diffusion tensor imaging has come along and given us the ability to start looking at some of those white matter tracks. It aids in preoperative planning, and we're starting to develop the functional MRI with the diffusion tensor imaging. That'll allow us to be able to identify specific white matter tracts that are deep that control speech. Because one of the problems when you're operating a tumor, even if Wernicke's is well behind you and Broca's is well in front of you, they have connections that are deep. So if you break those connections, you still get a deficit, even though you've left the gray matter intact. So this is giving us more of an ability to try to predict and plan. These are the images. They're a bit on the blurry side, but basically you can, this is a lesion here, and you can start seeing the tracts that go up and around the lesion. Another important question that we have is, does those white matter tracts go through the lesion? And that will allow us to know how safe that operation is. To give you an example, I had a 16-year-old woman who presented with headaches and some nausea and vomiting. She had a right facial paresis. In other words, her right side of her face was weak. However, her mother said she's always had a crooked smile since she's been like 3 or 4. And so the imaging shows a very large tumor in the thalamus. Okay? This lesion would have been considered unresectable. It's in the thalamus. It's, the morbidity of it's too high. With newer techniques of looking at what's going on with this lesion, we could see that there were a few white matter tracts going through, but the bulk were pushed medially, and we have other images to show they were basically split medially and also laterally. So we made a plan to basically go into this area and attempt to take this tumor out. Because this was, even though this was a slow-growing tumor undoubtedly, she was 16, she was going to be compromised from this tumor eventually. We had a gross total resection of the tumor. She did, as expected when you operate on the thalamus, have a deficit. However, it was transient, and with some rehab, she's back to the full function. So these are things that we are, basically the technology is not, we're going hand in hand with the surgery. In other words, technology is allowing us to look at things a little differently, approach things a little differently, and treat conditions that otherwise would have been considered unresectable or untreatable 10 years ago. And finally, interoperative mapping. So interoperative mapping, as most centers, is when you open up the brain, you're actually physically mapping the brain, typically with stimulus, like electrical stimulus. You can either do it asleep and or awake. And typically most centers will do it awake. You get the best results. So on our preoperative management, we always they go through a neuropsychological evaluation, look at because presumably there is an area that we're concerned about of what we call eloquent cortex. That's kind of an interesting term because I've heard other surgeons say that all of their cortex is eloquent, in which I think that is a good point, and we should always keep that in mind. But you'll hear the term eloquent cortex, and generally means areas of the brain will cause a permanent deficit if you injure them. The motor strip and the speech areas are the most obviously the eloquent cortex. So presumably if we have a patient that we're going to do interoperative mapping, they have a lesion close to these areas. We do what's a neuropsychological exam. We do the functional MRI that I showed you. We also do a WADA, which is basically an angiogram that puts half the brain asleep and sees what type of deficit you get when half the brain's asleep. Some people have, 95% of people have their speech centers on the left. However, if you're fully left-handed, there's a shot that you have them on the right. So we just confirm where your speech centers are, and that's kind of the gold standard. Interoperatively, we can do it as basically you put the patients asleep. Once we have everything open, we wake them up, stimulate the areas of the brain, and determine what areas of brain subserve motor function, speech function, and determine whether it's safe to take out that lesion or not. They're tested with various language skills, naming, comprehension, and sentence completion. And this is critical to have your neuropsychologist involved. There's a joke that if you can say your name and show two fingers on both sides to a neurosurgeon, you're neurologically intact. Neuropsychologists are much more in-depth when they're looking at deficits as well as when we're mapping. And this, just to bring up the slide again, is an example of mapping. We stimulate areas of the brain. Typically, we put little numbers on it because that'll correlate to different tasks that we have the patients do, as well as different outcomes. And then we determine, sometimes it has to be off neuronavigation because it's not obvious where the lesion is just by looking at the surface of the brain. So we'll have our neuronavigation. We know our lesion's right here. We'll map and see if taking this area is going to cause a significant deficit. If it is, then typically we'll pull out, and but sometimes it's a personal decision. If it's a tumor, if it's a GBM, some patients will risk a deficit to get as much of a resection as possible. So I always talk to patients beforehand and define our expectations and define our goals. This is just an aside. We can also map by placing grids. And some neurologists will argue that this is a more effective way of mapping. Basically, we put this on the surface of the brain. We open up, keep the patients asleep, put this on the surface of the brain, and then we close up. And then we take the patients to the epilepsy monitoring unit. They're fully awake. The neurologist will stimulate the different contacts and can very precisely locate where the speech centers are. However, this has to be a staged procedure. Some patients are not as willing to go through a staged procedure. And some of the cutting-edge technologies that are being applied to interoperative brain mapping actually is done by a group at UCLA. They're at the forefront of brain and neuroimaging. Now, this is an AVM. This is a vascular lesion, and it's very near a speech center. So the question is, can we take this out, or could Dr. Martin take it out, as Dr. Neil Martin's patient, safely without compromising speech? They did both a weight craniotomy, and they stimulated electrophysiologically in these areas, and found that there was significant activity, especially in these areas here. Now, a novel technique is basically taking the properties of the deoxy and oxyhemoglobin again. Basically, they absorb light at a different wavelength. So you shine a certain wavelength of light on deoxyhemoglobin, it'll absorb it more so than the oxyhemoglobin. So therefore, areas of the brain that are working hard have a lot of deoxyhemoglobin, will absorb more light than those are not, and you can detect that interoperatively. So and this is a map of that technique. The red basically means areas that were very active. The yellow, areas that are less so. So off both this mapping as well as the optical image mapping, they could determine that most likely that this would cause a deficit if you remove that lesion. And they actually backed out and sent the patient to radiosurgery. Just a note about interoperative imaging. Okay, we talked about mapping. I'm sure everyone's heard about the interoperative MRI as well as interoperative CT. There's a lot of good points about it. It allows the surgeon to put the patient back, take out the tumor, put the patient back into the MRI scan or CT scan, take another look, and see if there's anything you missed. Studies have shown that there is a slight increase in improved resections. There hasn't, to my knowledge, been a double-blinded control study or a controlled study period. So this data is still preliminary. And however, the benefit is questionable because the general idea, if you have a good surgeon who has clinical experience, the goal is to get at least 95% of the tumor out, and that's shown to have the best benefit. So we may be talking about 95% or 96% without the intraoperative MRI and 98 or 99% with. Remember, GBMs are often invasive. It's very hard to get a complete resection. Even if you do on imaging, some would argue you don't have a complete resection. So if there's no benefit, ultimately, it's probably because of that reason. In experienced hands, you should have an excellent result, no matter if you do the intraoperative imaging or not. And again, there's a lot of pros and cons to this, and we can talk about it after the talk. So, my conclusions got zapped. So what this is supposed to say is basically we've had a tremendous progress in the last 30 years in imaging. We went from basically images that gave us a best guess at what was going on, and a lot of times led to almost an exploratory operation, to nowadays that we have very precise ways of localizing the pathology. We have a good idea of what pathology we're dealing with before we get in there, and we have ways to do a minimally invasive approach, smallest craniotomy possible, to get the job done. Future directions, as I talked about, DTI, basically we need to, we can map intraoperatively the cortex. We're not as good at mapping the white matter. So when you start taking out a tumor, it would be nice to be able to map the areas of the brain that's below the surface. And that would give us a better idea if continuing on would cause a deficit or not. We have to become more consistent at fusing the diffusion tensor imaging, in other words, the deep white matter tracts, to the cortical areas. And that's in progress. We'll probably have that within the next couple of years, that we'll have reliable images that shows both the functional tracts as well as the cortical area. Optical imaging is a very exciting new technology. Right now, I think UCLA is the only center to have it. It's very technologically heavy, but that may be an adjunct to mapping. Probably the most promising technology coming down the pike is imaging specific pathology. In other words, we're able to create an antibody, meaning a chemical in the body that will stick to a tumor. And that is connected to an agent in which the MRI can detect. So basically, we will be able to, probably within the next few years, see lesions that we would not otherwise be able to see. In fact, GE is looking at an angiogenesis factor, meaning an antibody that targets angiogenesis. Angiogenesis, basically when a tumor sets up, it has cells, it starts dividing, it sends out a chemical, it tells the blood vessels to grow in. That chemical is an angiogenesis factor. So they've created an antibody to that and a way to image it so they can detect tumors before you can detect them on MRI scan. So that may be, maybe catching a GBM when it's, half centimeter in diameter, or you can't even see it on an MRI. Maybe we can, push it to the cure at that point. Maybe we're missing the boat because we always catch them when they're much larger. And then intraoperative imaging of specific pathology. There are techniques that are being developed in which, again, using antibodies that are bound to specific markers will actually stain the tumors, either fluorescently, so you switch on a specific type of light and the tumor fluoresces in front of you, making the operation much easier to define the borders of the tumor. So that's another step that we'll be taking very soon. So. All right, just some of the caveats. It's shown things that are very promising and very exciting about the future of surgical treatment of tumors. As Dr. Liao presented, there's a lot of things medically that are coming down the pike that are also very exciting for treating those tumors. My talk, of course, is mainly focused on the surgical side of things. So we've made amazing progress in the field. The only caveat is you have to keep in mind that technologies are tools. You really have to have a good team and individuals and teams that are very well versed in these tools, know how to use them properly, and have excellent judgment. So, all right, thank you for your attention, and I'll be happy to field any questions.